Hello, my name is Len DeVolio, and I have the great pleasure of having been invited to talk a little bit about what's next in AI in healthcare. I had sincerely hoped that this would be my first work trip in quite some time. I was really excited to get back in person with all of you. In fact, to open this um, talk, I was going to start with how wonderful it is that we're all back together and we've made it. And um, I think while we have all done a heck of a job getting to this point, the reality is we have a little more work to do, and I have to apologize for maybe waiting one more year, hopefully to all see you. So I'm sorry that this is asynchronous. I'll do my best to make the content to follow both entertaining and informative. And as I always try to do, I'll throw my email address up on the screen at the end and invite anybody who'd like to follow up to go ahead and send me a note, and I'm happy to talk. So I'm going to try to share my screen and put a couple of slides together. Let's try to pull these up. Okay, so hopefully you should all be seeing this. What's next for AI in healthcare? You've had a full day talking about AI, and I'm sure getting wonderful examples of how it's making a big difference or how it will make a big difference. I'm going to bring us out a little bit and try to give a 20,000-foot view of what's next. And, it's tempting to just start listing all of the ways that AI will affect healthcare, but I think it's probably more valuable to give everyone in the audience the tools that they need to assess what's next for AI, and not in healthcare, because healthcare, this $3.2 trillion industry that's really 50 industries. I don't think it makes a lot of sense to just start throwing out generalizations. I think instead I'd like to be able to give you all the tools that you need, the tools I use to figure out how do I make this matter in my little sliver of the healthcare world. And I think frameworks do generalize. So let's get at that. First, who I am, and at the same time, some of my disclosures. I'm the CEO and founder of a company called Cyft that helps providers of serious illness care identify value-based contracts, enter into those value-based contracts, and then use their data, among other things, to succeed in value-based contracts. I'm also an advisor to and investor in Firefly Health. I'm faculty at the Brigham and Harvard, and I know the Brigham changed their name, but I just can't get used to it. I'm an advisor to the Helmsley Charitable Trust Foundation, and I'm on the board of Youth Development Organization, which is an amazing organization out of Lawrence, Massachusetts. And if you care anything for education and the development of youth, I highly recommend you look them up. They do some amazing work. In my role, and God, I guess it has been almost 20 years, in my role, I spent my whole career trying to help organizations use data to get better at delivering healthcare. And that started with a PhD focused on the application of machine learning and natural language processing on healthcare data, but it has extended across the sort of research world with a number of studies trying to figure this stuff out, as a consultant in industry, in philanthropy, and nonprofits, and so on and so forth. And everything that I'll present in this talk, anything I present in any talk that I'm invited to give, is really as a result of lessons learned. My hope is to help you get there faster, learn from my mistakes, maybe avoid stepping on some of the same mines that I stepped on over the years. So in order to talk about what's next, it becomes really important to first answer some fundamental questions. And again, the goal is to give you all a framework with which to assess what's next for AI, where you're at in healthcare. Number one, you can't have a meaningful conversation about AI that's just too general. So we have to talk about what exactly it is and allows us to do. How can it add value? And I'm going to give you a hint here. When we say add value in healthcare, as much as my former 25-year-old naive researcher self would like to hold on to the idea that people do things in healthcare because it helps patients, every single individual I've ever met that went into healthcare went in there for that reason. But the reason technologies get adopted, the reasons investments get made, is because those investments either save money or allow new revenues to be generated. So we're all adults here, and we're going to have to square up with the fact that if you want to understand how a technology is going to be adopted, you got to figure out how it's going to make people money. What changes do we expect at the sort of policy and macro level? And then, and only then, if we combine these things in a line, we can start to get to what's next in healthcare for AI. So let's start with what is it? If you pay attention to what it is via the media or VC or the vendor community, I think we've done a terrible disservice in describing what this is, and we've made it harder for our customers to trust us and to adopt these technologies. We have positioned artificial intelligence as sort of man versus technology. And you'd be surprised to learn that humans don't like to be replaced by technology. And so why we would begin the conversation by continuing to position these technologies as being replacements for humans or competitive or dangerous or any of the other headlines that sell more papers or get more clicks these days. I guess nobody's buying papers. It really just doesn't set us up well for success. And so let's start by sort of moving past this sort of framing of AI as anything more than what it really is. 99% of the time when we're talking about these technologies, we're talking about math. And then this is math that we've had for a long time, but then when we combined it with faster computers, we open the door to create better math that can work faster and can make sense of more data. And usually we're talking about supervised machine learning. Now, there is a whole branch of AI that does try to take on both the philosophical and technical challenges of how do we create an artificially intelligent, near sentient being. None of that matters for people who are setting out to improve healthcare in the near term with better math. We're mostly looking at supervised machine learning, which has probably already been touched upon in other sessions, but it's really just when you give examples to this math plus computers and you say, learn what it is that makes some of them positive and some of them negative, some of them red, some of them blue, some of them patients that are heading toward bad outcomes, some of them patients that are heading toward good outcomes. It's learned by example math made possible with fast computers. When you frame it up in that way, it suddenly seems rather silly to talk about replacing doctors with math, or that math itself is racially biased, or that math will revolutionize healthcare. This math plus computers has enormous potential, but make no mistake, it will be us, the people working on solving these problems, the people listening to this talk, that ultimately decide whether or not they use that math in responsible ways with unbiased training sets, anticipating all of the things that could go wrong, grounding that math in solving meaningful problems, or if they use it irresponsibly and frame it up as being human replacement and throw in terribly crooked training sets without thinking about what could go wrong when we do things that way. This is a tool. This is a set of capabilities that we will decide how to put to use. Now, the reason why this map is so important is because it gives us new capabilities. It allows us to solve problems with a greater degree of personalization. So rather than one-size-fits-all care models, or risk stratification that looks for the people that already cost the most, we can now start to think about, what is it that makes you, the 56-year-old, otherwise healthy adult that is now presenting in the emergency department and has these certain labs and has this particular set of histories, what is it that makes you who you are? What is it about your pattern that would indicate that we need to care more or less, more immediately, do things more or less urgently, deliver certain types of interventions? We can now move away from one size fits all. And like every other industry for the last 20 years has been doing, we can begin to make personalized recommendations. We could do this through the benefit of more and more data. We're no longer limited to a few rules or a logistic regression that learns from 7 to 10 variable points. We can build models with millions of data points. And unlike static math or static rules, if we do this right, the models that we build have the potential to continue to learn with new examples, which is fantastic. So this is math that sets us up to learn in ways that were never before possible. So when we think about how this math can help us, we think about where in healthcare does it make sense to use more data to make better, more personalized recommendations more quickly and to evolve as we go. The analogy that I think is more helpful than, computers replacing humans or robotic doctors is Google Maps, right? Google Maps allows us to make better decisions by taking in more data that we as doctors or humans or business people don't have at our fingertips all the time, but Google Maps does. It can tell us the fastest point between A or B based on what thousands of people have done in the past, based on what thousands of people are doing right now. And as is the case, if done well in medicine, it shouldn't take the wheel. It should make recommendations. It should present to us where it thinks we will get by taking these recommendations. And then it's up to us, the driver, to figure out which way to go. So to get to what's next for AI in healthcare, now that we understand what it is, we need to figure out what questions are most important for where it's going. And I'll be honest, most of the time when we talk about what will inhibit or propel the growth of AI in healthcare, we talk about, do we have enough data? Are the models biased? How accurate is the model? Does it include social determinants, which I'm still trying to figure out what that means. These are all really important questions after you've already made the decision to implement this math to solve a meaningful problem. I think they're all red herring questions when it comes to trying to understand whether or not this will be adopted and where. This is the most important question I have found in my 20 years of doing this work. If you want to figure out how and whether it'll make a difference and when, figure out how and whether and when it will help someone save money or discover new revenues. And you can't do that in healthcare, treating healthcare as one industry. Healthcare is probably 50 different industries, each one of which can have competing economic incentives. The pharmaceutical manufacturer makes money when they sell more drugs, the payer loses when the patients use more drugs, and so on and so forth right down the line. So if you have 50 different industries, each with different economic reimbursement policies and incentive structures, you can't really talk about what's next in AI without picking an industry. So understand the capability. What does it allow us to do? And it's just use more data to deliver insights faster that are more personalized. Then figure out how do people get paid in your industry, in which problems, if I could just make better decisions a little more often, if I can shave 2 to 6 minutes off my commute every day, now apply that to the business that you're focused on, that's where you'll start to figure out where traction can happen. And just to make this point one more time, if you're an outpatient surgical center and you get paid to deliver more surgeries to more people or to use more expensive devices, you'll use artificial intelligence to figure out how to schedule more surgeries that involve more expensive procedures, period. That's how it will be used. Even though we all know, and you're welcome to go to the Cyft website and see a case study where we used artificial intelligence to figure out which patients are most likely to not benefit from a surgery. Good luck selling that to a surgical center that makes more money from delivering more surgeries, especially during or just after COVID. So you have to square up with this economic reality. Now, if you're a Medicaid managed care organization, you might use AI to discover which patients need a visit from a care manager sooner. And if you're getting really good, it may be because you've created personalized models and you've now figured out that this patient is nearing end of life and they and their family should be prepared with conversations about goals of care, or you should figure out which patient's most likely to fall sooner. Personalized recommendations designed to avoid unnecessary expense make sense when the organization has a fixed budget with which to keep people healthy. with that, let's start talking about what macroeconomic or policy changes are coming down the pike that might allow us to make better decisions about where this is going. Let's be clear, healthcare in the US is not a free market economy. Almost all the money in healthcare moves around based on healthcare policy. So in healthcare, reimbursement policy eats strategy and culture for breakfast. If you don't understand how people are paid in the narrow sliver of healthcare in which you work, and I don't care if you're a business analyst or the clinician or a data scientist, if you want to understand what is or is not going to be adopted, you need to spend time reading how exactly people get paid in the part of healthcare that you're in. In the major shift that we're seeing that I think will affect at least the care delivery side of things, if not the care delivery side, the insurance side, the device side, the pharmaceutical side, is basically the federal government, the biggest payer in healthcare in the US, if not the world, is fully committed to moving more of healthcare reimbursement away from fee-for-service, which means I'm going to give you more money to deliver more care and more complex care, toward value-based care, which means I'm going to give you a fixed budget with which to keep people healthy. And we have seen through the last several administrations a continued march toward the introduction of more value-based contracts. And now we're seeing for the first time the threat, if not promise, I think it's a positive development, of mandatory models. So it will no longer be mostly carrot, maybe a little bit stick. It's basically going to be mandatory two-sided risk models where you have a fixed budget as a provider or a provider organization, and you either deliver care for under that budget and make more money, or you blow your budget and you cut a check. And the downstream repercussions of this are tremendous. And I won't go into every rippling wave that comes out of this splash in the pond, but suffice it to say, if you as a provider organization have a fixed budget, you suddenly need to figure out how to use analytics to get out ahead of unnecessary expense to keep people healthy. And if you care about that topic, the intersection of value-based care, analytics, and care delivery, we've been doing a journal club for probably about a year now that takes on this topic directly. Go out to Cyft. I'm sorry for the plug, but I believe in what we're doing, and it doesn't cost anything. And we've had people like Dr. Jeff Brenner and most recently Brad Smith, former director of CMMI, come on and talk about the journal articles they've written and where they see this stuff going. So when you have this movement, suddenly, as you take on more risk, analytics becomes more important. AI has a bigger role, a critical role. And we're seeing not only more organizations enter into these programs, but we're seeing them start to make money. And we did an analysis of 133 double-sided risk organizations in 2019 that represent millions of patients worth of care delivery. And what you see is out of 133 of them, only 4 of them had to cut a check to government. And another 19 didn't make or save enough money to get a check, but then the rest of them did. So, pretty big carrot, the threat of a stick coming down the pike, demonstrations of success. I think this is going to be the greatest driver of adoption for all sorts of advanced analytics. So just to recap, it's the ability to learn and personalize. That's what it is. That's what AI is. Then you pick a very narrow subset of healthcare industry, read the reimbursement policies to understand where would learning and personalization make money, to be candid. I'll just give you a really quick example. So serious illness care, the space that Cyft is in, we're talking about patients in the last 2 to 3 years of life. These are patients that are pretty sick. It also happens to be an area where we deliver, as a nation, terrible care, not in alignment with what patients all say they want when they're asked and when studies are conducted. So tremendous waste, bad care, and an explosion of value-based contracts. So I want to just highlight, if you're delivering serious illness care, you're either a geriatrician, usually a geriatrician delivering primary care in homes or facilities, or your palliative care docs or your hospice docs. And from the outside looking in, you just think, well, they all deliver the same kind of care. They all have the same incentive. But if I want to understand how AI will make a difference, even in this very narrow substrate of healthcare delivery, I need to recognize how they get paid. So if they get paid via fee for service, then they will use AI to maximize the number of visits they deliver and to maximize the number of hospice stays because they get paid to deliver services. Now, if they're an MA plan and they're involved in serious illness care, the most valuable use case for them is to identify people to move into hospice because you come off the books of the MA plan. And if you don't understand that, it's hard to sell AI to folks in that space. See, the Center for Medicare, Medicaid Innovation came out with a value-based contract called PCF-SIP, which they had everyone prepare for about a year and a half, then they pulled the plug on it. But if you were helping organizations participate there, then you needed to help them identify patients because it was a transitions program. They had to use AI to find patients to transition to a PCP or a hospice in an average of 8 months or less. That's a different use case driven entirely by the contract that they were in. If you're in direct contracting, more specifically direct contracting high needs, which is another value-based contract, you had the opportunity to do concurrent coding for HCC codes because the federal government recognized that these patients were so acute and their conditions could become more acute at any moment. So you had the ability to constantly update the acuity of the patient based on the HCC code. And that was the most valuable use case for artificial intelligence. And if you're in an MSSP, you had even another set of use cases. There it's all about admission reduction, plus making sure that you coded patients based on their acuity. So within this one seemingly narrow niche of healthcare, you have very different uses of AI depending on how you're reimbursed. And that's the thing I need y'all to take away, because I don't care which niche of healthcare you're in, this will be the case based on the way they get reimbursed. The very last point I'd like to make is, just as each of these use cases required a different approach and a different way of talking about it and had a different ROI, you'll know when you've succeeded when nobody involved is talking about AI. They're talking about how you help them solve a business or clinical problem that led to an ROI. That's it. If you're talking about p-values and F measures and ROC curves, you're already looking at the wrong metrics. It's ROI for solving a very specific business problem. So that's the end of my talk. I hope this is useful for you. There's my contact information. I would encourage anyone to send me a note that has any questions or would like to follow up on anything. I really appreciate the invitation. I hope all of you have a safe and productive rest of your time at Cyft, at HIMSS, and feel free to shoot me a note. Chris and Mike and others, thanks again for the invitation, and I can't wait to see all of you in the not too distant future in person.